about anatomy. We're going to start out with the mucosa. We all know that we have different types of mucosa in our mouths. We have masticatory mucosa, we have lining mucosa, and then we have that specialized mucosa, okay? Masticatory mucosa is found in the hard palate, the attached gingiva. We did put the dorsum of the tongue within the masticatory mucosa because it is keratinized, but we also know that there are taste buds on the tongue, so it's also referred to as specialized mucosa, okay? But the masticatory mucosa is keratinized, and because it needs to be protected during the process of chewing. So when we chew, what we're doing is we can cause damage to that tissue, so that keratinization helps that tissue to withstand the forces of chewing. So when we look at masticatory mucosa, we have the epithelium, which is that outer surface of the tissue, and then we have the lamina propria, which is that connective tissue that's found directly under the epithelium. Okay, so it's all coming back to you. It's a little bit of histology, a little bit of head and neck, right? Lining mucosa is pretty much everywhere else. Okay, so when we look at the cheeks and the ventral surface of the tongue, we look at the alveolar mucosa, all of that loose, more movable type of tissue is the lining mucosa. Lining mucosa has the epithelium on the outside. It also has that connective tissue, or lamina propria, that's found underneath it. And then there's a submucosal layer that supports that loose connective tissue so that it's not falling apart every time something hits it. Okay, so if we're chewing and we happen to scrape that lining mucosa, we may injure it a little bit, but it's not ripping apart when we're eating. And so all of the softer areas in the mouth is what's going to have that lining mucosa. In the mouth, the lining mucosa is moist. We have glands underneath that help to keep the tissue moist. And this tissue is able to be stretched and compressed, which allows the muscles and lips and everything to move. If this tissue was stiff, like the hard palate, we would not be able to move our lips around. So when we try to talk, we wouldn't be able to talk normally because the tissue would not allow the lips to move around. So this tissue is able to be stretched and pulled and compressed. When we're giving an injection in the mouth, it is much easier to give an injection when we have to put the needle in lining mucosa than when we have to put it in the masticatory mucosa. It's also much more comfortable to the patient if we're injecting in lining mucosa. Most of the injections that we do put the needle in lining mucosa. But there are a couple that we do have to put in the hard palate, and that can be quite uncomfortable for the patient. Then when we talk about bone, we learned back in head and neck that we have cortical bone and we have trabecular bone. That cortical bone is the more solid type of bone. Trabecular bone looks kind of like a sponge. So it has lots of little openings and passageways through the bone. When we look at the mouth, in the mandible, the cortical bone is much thicker. So if we were going to try to give an injection and infiltrate around a mandibular tooth, the cortical bone is going to prevent that anesthetic from getting to the nerve of that tooth. So it is much harder to infiltrate a mandibular tooth if we're trying to anesthetize it. In the maxilla, the cortical bone is much thinner. So when we give an injection in the maxillary arch, we're able to inject that solution. If we only want to numb one tooth, we can inject that solution right above that tooth and get good anesthesia in that area because of the trabecular bone is much thicker, cortical bone is much thinner, so that solution is able to get into that bone and get to the nerve and anesthetize that tooth. Now, if I wanted to anesthetize tooth number 7, and I put the needle right above number 7, I'm also going to get other teeth. Okay, it's not like I'm going to just numb one tooth. But if I only have to work on one tooth, it's much nicer that I can just give one injection over that tooth and not have to, anesthetize an entire quadrant like we have to do in the mandible. Okay? You all follow me with that? Okay. Now, when we're giving an injection, we have to be careful with the periosteum that's covering that bone. When you give an injection, you want to get as close to the bone as you possibly can so that that anesthetic is able to get through that bone quickly. If we're far away from it, then it has to travel through a bunch of soft tissue. If we are far away from that site and then the injector has to get through all of that soft tissue before it can finally get to the tooth, and at that time, sometimes there's not enough anesthetic left to adequately anesthetize that tooth. So you want to get as close as possible, but you do not want to nick or scrape the periosteum with the needle. There's a lot of nerve fibers in periosteum. So if you take that needle and start poking it into the periosteum, it's going to be extremely painful to the patient. Okay? I've heard people that said their trick when they give an injection is to take the needle, take it all the way to the bone, and then walk it down the bone until they get to their site. And it's like, yeah, that's a perfect way of getting to the right spot, but every time you touch that periosteum, you're hurting your patient. Okay, so ideally, you're going to give the injection as close to the periosteum as possible without actually touching the periosteum. So again, because in the mandible, that cortical bone is so much thicker, we typically do not infiltrate mandibular teeth. Now there is an exception. Sometimes in the anterior region, even though we know the cortical bone is thicker in the mandible, in the anterior region of the mandible, that cortical bone can be kind of thin, especially someone who has had some bone loss. So occasionally we can infiltrate in the mandibular anterior area and get adequate anesthesia. We typically use an anesthetic that is able to get to the area a little bit better, and we'll talk about that when we start talking about the anesthetics. So let's look at some mandibular anatomy, because there's specific things that we want to look for that are going to help us to get the proper placement when we put the needle in to give a certain injection. So when we look at the mandible, remember the coronoid notch? As you follow down the ramus and get to the body of the mandible, this little angle right here, the inside of the elbow of the mandible, that's the coronoid notch. When you're going to give an inferior alveolar injection, you have to find that coronoid notch, because that landmark is going to show you where you need to go when you place the needle. So the first thing you do is palpate for that coronoid notch, and then you leave your thumb or your index finger on that notch as a reminder exactly where it is.
For which injection?
For the inferior alveolar. And we will show you that when we actually talk about how to do the inferior alveolar injection. Okay? Another landmark that we want to watch for is the mental foramen. Now sometimes you'll hear that you can palpate the mental foramen. I'm telling you, highly unlikely that you will ever be able to palpate a mental foramen unless it is an edentulous person who has lost a lot of bone, and now that mental foramen is close to the upper surface of the alveolar ridge. When you go to palpate, if you feel a depression in this area, what you're feeling is the depression between the roots of the two premolars. Because the tissue attachment is up in here, so if you try to palpate down here, there's too much tissue there and you can't get to it to palpate it, okay? So if you're ever in a class and someone tells you to do that, just nod and say, okay, and then you know I'm full of crap, okay? All right? Mental foramen is an important landmark when you're giving the mental injection. All right? We know that the inferior alveolar nerve comes down, enters into the bone, branches come off to get the teeth. When it gets to the mental foramen, it branches into the mental nerve and the incisive nerve. Mental nerve comes out and gets this soft tissue right here. So when you give a mental injection, basically what you're doing is infiltrating around this area where the mental foramen is to catch that nerve. Now it's called a mental nerve block, but with the technique, what you're doing, you're definitely blocking that nerve, but you're doing it by basically infiltrating the solution, okay? When we look at the inside of the mandible, the biggie is, well, first of all, we've got the nerve that comes down, and then the biggie is the mandibular foramen. Do I have that circled back? Okay. So the mandibular foramen, we all know there's the mandibular foramen. There's the lingula. We know a tendon attaches to that lingula. So the inferior alveolar nerve comes down, enters the mandibular foramen, comes through, and then branches come off to get the teeth, gets to the mental foramen, and then branches into the mental nerve and the incisive nerve. Where this circle is the area where you want to be injecting when you give an inferior alveolar injection. Because of the denseness of the cortical plate in the mandible, we have to catch the nerve before it enters the mandible. So we're going to inject in this space right here so that we can block that nerve. When we block that nerve, we're going to get more than one tooth numb. Okay, we're going to get a quadrant numb. So with some maxillary anatomy, we all know where the infraorbital foramen is. The infraorbital nerve is going to get the upper lip, lower eyelid, cheek, and side of nose. When we give an infiltration down here, sometimes that solution will catch a little bit of that infraorbital nerve. So sometimes patients say, oh, my nose is numb. You know, you give a canine injection, they're going to say, oh, my nose is numb, okay? Because they're catching just a little portion of that infraorbital. In order to do an actual infraorbital block, you have to take the needle and get it just below the rim of the orbit of the eye. And we're not going to teach you that because we don't want you doing that. Okay?
Right here, outside the face and everything.
What's that?
Like outside on your face and everything, like
Outside
right
on your
here.
face.
Like you'll take a needle and just put it right there.
No, you go from the inside
Okay.
and you keep going and keep going until you're about that spot. Okay? So yeah, you're not gonna learn that. But we do know that as part of the maxillary nerve anatomy, we have several branches. One of those branches is the PSA. Okay, so we were gonna learn how to do the PSA. And with the infraorbital nerve, we know that before it exits the skull, there's a couple branches that come off, the ASA and MSA, and those are going to supplies sensory innervation from the incisors, canines, and premolars. Okay, is it all coming back to you? Yep, kind of, sort of, maybe. Yes, that helps. All right, so when we look at the palatal side, we look at the anatomy in the palate, we know that we have the nasopalatine or incisive foramen, and we know that the nasopalatine nerve comes out of that foramen, and it provides sensory innervation on the palatal side, canine to canine. We also have the greater palatine foramen, which is typically found between the second and third molar. Sometimes it can be a little bit more anterior than that. The greater palatine nerve exits that foramen and provides sensory innervation from the first premolar to the third molar. There's also that lesser palatine nerve that comes out of the lesser palatine foramen, and we don't want to go there. If we numb the lesser palatine nerve, that's when we start to get that soft tissue anesthesia. Not going to kill the patient if you do that, but the patient may freak out on you because they're going to think that they can't breathe and they can't swallow. They're just not feeling it, okay? They can scream and yell, they can breathe. All right? So the two palatal injections that you guys are going to learn will be the nasopalatine and the greater palatine. All right, talk about the trigeminal nerve. We know that there are three branches of the trigeminal nerve, V1, V2, and V3. The V stands for 5, because it's cranial nerve 5. V1 is this first branch here. V2 is the middle one. V3 is the biggie. Okay, so V3 is the largest branch of the trigeminal nerve. And we know that the foramina for the trigeminal nerve are found in the sphenoid bone. And remember that V1, or the ophthalmic division, the foramen is the superior orbital fissure. For V2, or the maxillary division, it's foramen rotundum. And for V3, or the mandibular division, it's foramen ovale. So SRO, standing room only. So when we look at the trigeminal nerve and the areas of innervation for each one of these divisions, when we look at V1, and again it's the ophthalmic division, it is completely sensory. There's no motor intervention with V1. We already talked about the foramen being the superior orbital fissure. And so you're going to get sensory innervation to the scalp, the forehead, the top of the eye, down the center of the nose to the tip of the nose. Remember the question on one of the exams in head and neck? He said if a fly goes into your eye, which nerve is going to give you that sensory innervation? Kind of remember that a little bit? It was V1, because it also gets the cornea of the eye. All right, V2 is the maxillary division. It is also all sensory. V2 is going to give you some of the side of the cheek, the side of the nose. For us, the important thing is the maxillary teeth. So we will get sensory innervation from all of the maxillary teeth from the maxillary nerve or one of its branches. The mandibular, V3, mandibular division is both motor and sensory. Again, it's the largest of the three divisions. you are going to get innervation from the side of the face up to and into the ear a little bit, because we have that auricular division or branch off of B3, and all of the mandible. When we give an inferior alveolar injection, because the auricular branch is so close, sometimes patients will say, oh, my ear's numb. Okay, that's normal. It can happen, doesn't always, but it can happen. All right, so let's look at V2 specifically and its branches. So first of all, we have the zygomatic branch. Zygomatic branch is what's going to get that skin on the cheek and the side of the forehead. Remember again, V2 is entirely sensory. There's no motor innervation with V2. PSA, that's the one that's going to branch down to the maxillary molars, except for what? Mesiobuccal root of maxillary first molar. Good. The next branch is the infraorbital. And we know before the infraorbital exits the skull through the infraorbital foramen, there are two branches that come off of it. MSA, ASA. MSA is going to get what? Mesiobuccal root of the maxillary first molar and the premolars. And the ASA is going to get you canines and incisors. Yes. All right, and the next branch is the descending palatine. So now we're looking at a palatal branch. And from that, we're going to get the greater and lesser palatine nerves. Greater is sometimes referred to as the anterior, and the lesser is sometimes referred to as the posterior. There is no indication for anesthetizing the lesser palatine in dentistry. Well, in your dentistry. And then we have the sphenopalatine branch. And the sphenopalatine branch will then branch into the nasopalatine. Okay? So if we're looking at the anatomy here, we've got the maxillary nerve coming off. Here's the zygomatic branch. We then have the PSA that comes down to get the maxillary molars, except for the mesiobuccal root of the maxillary first molar. We have the infraorbital. Before it exits the skull, it branches off into the middle superior, or MSA, and the anterior superior, or ASA. All right, so the infraorbital nerve, if we anesthetize the infraorbital nerve, this is the extent of where this nerve is going to provide sensory innervation. So we can see lower eyelid, the side of the nose, and down towards the maxillary bone. Okay, so if we inject here, we're most likely going to get these terminal branches of the infraorbital, and that's okay. All right, PSA, MSA, and ASA, they are sensory innervation to the pulps and the buccal or facial tissues of the maxillary teeth. All right, so now we've cut the skull in half and we're looking at the inside. So now we're going to look at the palatal branches. So here we can see this is the greater palatine here. This is the lesser palatine here. And then here's the nasopalatine. Okay, so these are all eventual branches from that original maxillary nerve. These are all sensory innervation to areas of the palate. Greater palatine, this isn't the best picture because I don't like the fact that they put up the color all the way to the central. But if you look at the nerve branches, do you see how they stop right at the canine? So the greater palatine is going to provide sensory innervation of the palate up to the canine, but not including the canine. There's the premolars and molars. The nasopalatine is going to provide sensory innervation of the palate from canine to canine. So if you give a proper ASA injection, if you give a proper nasopalatine injection, you're going to get both the right and left sides. If you only want to anesthetize one side, then typically we go off of from the foramen a little bit so that we just catch one branch. Okay? But if you give the nasopalatine the way we showed you to give the nasopalatine, you will have anesthesia from canine to canine. All right, so let's look at the mandibular branches. The mandibular branch will have an anterior division, posterior division, and again, we said that the B3 is both motor and sensory. So the sensory portion of the anterior division is the buccal, or as we call it, the long buccal nerve. The long buccal nerve is going to provide that sensory innervation to the buccal tissues around the molars. Okay, we're going to look at that here in just a second. It also provides motor innervation to the muscles of mastication. When we look at the posterior division, the sensory portion is the auriculotemporal. Remember when I said we give an IA, sometimes we also will get that auriculotemporal, and so the patient will say, oh, my ear feels a little numb. The inferior alveolar, which is a biggie for us. The lingual, we're going to look at the lingual in relation to the inferior alveolar, because when we give the inferior alveolar, we typically are going to get the lingual as well. And then we have the motor innervation to the mylohyoid muscle. So when we anesthetize, we are not anesthetizing to try to stop the motor function. We are anesthetizing to stop that sensory function. All right, so we're looking at B3, mandibular nerve comes down. We can see the inferior alveolar comes in. It's not really showing it, but it'll go through that inferior alveolar foramen into the bone. And then we start to see the branches coming off to the teeth. At the mental foramen, it will divide into the mental nerve and the incisive nerve. The incisive nerve stays in the bone and provides that sensory innervation to the anteriors. The mental nerve comes outside of the bone, and it provides that sensory innervation of the soft tissue. All right, and I already talked about those. Oh, the long buccal is not shown on this so well. This, I think this white one here is supposed to be the long buccal. This picture is not showing it. And then the auriculotemporal, you see how close it is. So when we give an injection, sometimes we catch this branch of the auriculotemporal, and that's why they have the thumb here. All right, so this is showing the inferior alveolar as it comes down and enters into the bone. It's going to provide that sensory innervation to those posterior teeth. When we get to the mental foramen, that's when it's going to branch off, and we'll have the mental that comes to the outside of the bone, incisive that stays inside the bone. The lingual comes down alongside the IA, and it's going to provide sensory innervation from the half of the tongue that it's approximating, as well as the lingual soft tissue. The buccal or long buccal will come towards the outside, and it provides sensory innervation of the soft tissue on the buccal side of the mandibular posterior teeth. All right, so now we're going to talk about the pterygomandibular space. Did I talk about that when we had head and neck? Yeah, we talked about that. Good. So this will be a review as well. So the pterygomandibular triangle, or the pterygomandibular space, is this space on the inner side of the ramus, of the mandible, where the nerve is going to be traveling through. Now, the thing to remember is that everybody's anatomy is different. So it's not like everybody has the same size space and everybody's nerve travels exactly the same way through that space. Sometimes the nerve is high in that space, sometimes it's low in that space. So when you give an injection, you're giving an injection with the assumption that it's somewhere in the middle. If that nerve is farther away from where you injected, it's just going to take a little longer for that person to get numb. So you don't want to just anesthetize somebody and then get started working right away. You want to give them a little time to get numb. Okay? Sometimes it's far enough away that the injection we gave is not enough and we have to give them a second. So we give them a booster so we can get that solution pushed through that space. All right? So this triangle is an upside down triangle. And the triangle is bordered by the ramus on the lateral side, the lateral pterygoid on the top, and the medial pterygoid. I'm sorry you can't read this very well. I tried to find a color that would show up well and I couldn't find anything. So this would be the ramus on the lateral side, medial pterygoid on the medial side, and the lateral pterygoid on the roof, or the base of the upside down triangle. So the nerve, again, is going to be traveling somewhere through that space. So when we inject, we want to be injecting in that space. So when we look inside that space, the first thing that we're going to see is the inferior-alveolar neurovascular bundle. The inferior-alveolar neurovascular bundle includes the inferior-alveolar nerve, the inferior-alveolar artery, and the inferior-alveolar vein. They're all traveling along each other. This one, when we give this injection, we always want to aspirate because the artery and the vein are so close to the nerve that sometimes we have that needle in a blood vessel. So we aspirate to make sure that we're not in a blood vessel. Okay? Now also in that space, we'll find the lingual nerve. Now the lingual nerve is not traveling within that neurovascular bundle, but it's close enough that when you inject in that space, you usually get the lingual nerve as well. Okay, so half their tongue and the tissue on the lingual side of the teeth will be numb. Yes?
But just out of curiosity, so like what would happen if like someone didn't aspirate and they didn't know that they were in a blood vessel? What would happen?
It depends on the individual and their medical history.
Okay.
For a healthy adult, what will happen is their heart will start beating like crazy.
Okay.
It'll last only for a few minutes if you're that is if you're using something with epinephrine in it or is some sort of a vasoconstrictor. The heart will feel like it's pounding and it'll be really, really fast.
Okay.
With the anesthetic, you have a greater risk of having toxic effects of the anesthetic. If it's a healthy individual, it's probably not enough that's going to cause toxic effects, but they're not going to get numb either.
Yeah.
Okay, so we don't want to do that because we can't regulate how much of that anesthetic that they're getting into their bloodstream.
Right.
Okay, you have a question?
I just had like a little story. My aunt had a root canal done and she said her heart was beating like super fast. It's never happened before. So I'm thinking they maybe aspirated and like didn't know. But because she had no
Possibly.
nerves, because she's already had a root canal before.
Yeah,
So
yeah, possibly. Sometimes though, whenever you use an anesthetic that has some sort of a vasoconstrictor in it, it will cause someone's heart rate to go up, and it'll cause their heart to beat to beat more forcefully.
Mm-hmm.
So it could be that yes, they did have an intravascular, or a portion of it was an intravascular injection. More likely, it's just the fact that there was epinephrine in that anesthetic, and it was enough to cause her heart to beat fast.
Is that something we would tell our patients prior to the injection?
Tell them
like if we were giving them an injection that had epinephrine in it, would we say, okay, you might feel like your heart is beating, or it's gonna be a little
You
faster?
can't, it really depends on the patient. You know, if you've got somebody who's already freaking out, you know, since that is such a, it's a normal thing to have happen, I don't know that I would necessarily tell every patient that. But if they start to act funny, I'm like, oh, does it feel like your heart's beating fast? And they'll, you know, you can always tell. When someone is having some sort of a reaction, you can always tell that there's something going on. And so you just ask them, you know, it's like, oh, did it feel like an electric shock? Because sometimes people will feel that when you get the injection. And they're like, no, it's just my heart beating fast. I'm like, oh, that's normal. It's because the medicine that we use, we wanted to keep it in the area for a longer period of time to keep you numb longer. And so because of that, sometimes it makes your heart beat a little bit faster. Then it'll go away in a couple of minutes. Okay? Yes?
This might be dumb, but is it possible to get both a nerve and an artery, or are they big enough, or bigger than the needles that you want
Is it possible to like
to inject?
inject? Probably not.
Okay.
Probably not. The thing to remember is when you are injecting, you know, the sheath that's covering the nerve is pretty thick. And so if you go in and you actually touch that nerve with a needle, usually it's enough that the nerve will actually kind of pull away a little bit, okay? If you touch it, yes, they'll get a shock. If you're right next to it and you don't touch it, they'll get a shock, okay? And that's normal, and you know, there's a way of talking a patient down when that is happening. But for you to get the nerve and the blood vessel, I think it would probably be fairly hard to do that. Yeah. I guess it could happen, but man, you'd have to be really good to get that to happen. All right, so here we're looking at pterygomandibular space. And we're looking at different vessels that are in there. So the first thing we're gonna look at is right here. This area here is kind of hard to read, but this is the inferior alveolar nerve. All right? Now, one of these is a vein and one of these is an artery. Based on what you've learned in the past, which one is the vein?
Blue one.
The thinner one.
The one on the bottom. And why is that?
Has a
Because it's
thinner,
blue? No, that's not the answer.
has thinner muscle.
Thinner muscle. Yeah, remember the tunica media? Yeah. The muscle layer is much thinner on a vein than it is on an artery. Okay? So this, oh, got a little excited here. This right here is the inferior alveolar neurovascular bundle. In that space, we also see this little nerve hanging out right here. That's not part of that bundle. What is that nerve? The lingual nerve, because we know that the lingual nerve is in that space also, but it's not actually part of that neurovascular bundle, the IA neurovascular bundle. All right. So, just, well, I'm a little ahead of myself with this, but if you're going to have nerve damage from an injection, which is highly unlikely, so don't go into clinic thinking that this is going to happen to you guys. It's highly unlikely to cause nerve damage when you're giving an injection. But if you were to do it, typically it's the lingual nerve that gets damaged, not the IA. And that's just because the lingual nerve is much smaller. So the sheath around it is not as thick. Okay? When someone is having a tooth extracted, third molar extracted, and they have paresthesia afterward, more commonly it's the lingual nerve because it's a much smaller nerve and it gets damaged a little bit easier. All right, so we had also talked in head and neck about the facial nerve in relation to where the trigeminal nerve is. And we know that the facial nerve is found, it travels down right behind the mandible and then traverses through the parotid. Remember, it doesn't innervate the parotid, it just kind of sneaks through it. So, what would happen if you went too deep when you're given the IA. You didn't stop where you were supposed to go, and you went too deep. You could go back here and you could anesthetize the facial nerve. We'll talk about that a little bit later in this semester. When you anesthetize the facial nerve, what happens? You get temporary paralysis of the muscles of facial expression.
No, I think that happened to me when I was getting a filling once because my eyebrow went numb when I was getting filling.
Your eyebrow, if it was just your eyebrow, did
Well,
you have
it
any
was-
drooping or anything?
It was all my whole nose and all of this felt numb and I couldn't move it.
That's probably more of, they gotta be infraorbital.
Oh.
Yeah,
That was
because,
weird.
yeah, typically if you get the facial nerve, the patient can't close their eye.
Really?
We have to patch them up. We actually have to close their eye and patch them up. And then you have to talk them off the ledge, okay? It's a temporary thing. It will go away as soon as the anesthesia wears off. Hopefully you use something short-acting like bupivacaine and not something long-acting like Marcaine, okay? Because if you use something long-acting, they're gonna have that facial paralysis the entire time that anesthetic is working. So we don't wanna go too deep. Yes?
If you go too deep when that happens, does it only hit like that upper part of the face, or do you do another IA, or does it infiltrate enough to get like the whole left side?
If you get the facial nerve, depending on where you get the facial nerve, anything that's branching after it or distal to the area where you injected will have the
You have to like
paralysis.
do another IA if they have that happen.
I would not, if I hit the facial nerve, or not hit the facial nerve, but if I anesthetize the facial nerve, I wouldn't be working on it for the rest of the, I'd say, I'm sorry, the anesthetic traveled a little bit farther back than we wanted to. What, we're just gonna, cancel this appointment at this point, I'm gonna tape your eyes shut. You're gonna be numb for a little while.
Tape your eyes shut. What if they gotta drive home?
Yes, yes. And I will charge you for that anesthetic.
Have you done that?
Have I done it? No.
Okay.
Nothing happened here. Have I seen it happen? Yes.
Like here in clinic.
In this clinic, no. I've seen it at the hospital with our residents, but I've never seen it here. And I will never see it here.
That's right. That's right.
All right, so we gotta think of some vascular considerations. When we do a PSA block, we're gonna learn that there's a PSA infiltration and then there's a PSA block. When we look at the anatomy, remember when I talked about that vascular bundle that was, that I said, when we talk about, when we go into pain control, we're gonna talk about how you can cause a hematoma there. When you're giving a PSA block, because of that bundle of blood vessels in the area where you're giving that injection, there is a greater chance of nicking one of those vessels and getting a blood clot that forms, okay? Is it a permanent thing? No. But it can cause pain and it can cause trismus, which means they can't open their mouth well, okay, until it goes away. We'll talk about that later in the semester. If something like that happens, what are the steps that you need to do to take care of that, okay? When you're giving an inferior alveolar injection, because the nerve is so close to that inferior alveolar artery and the inferior alveolar vein, there's a greater chance of giving the injection into a blood vessel. So what do we do when we're giving both of these injections? Aspirate. Good. Now your book will say, or people will say, when you're giving a mental injection to avoid going into the canal, and that is true, you want to avoid going into the canal, but it's extremely hard to go into the canal. If you look at the anatomy of the mental foramen, there's like a little lip on it, so the hole is back here, okay, because of that lip. So in order to go into the canal, you have to take the needle this way to inject, okay? And nobody does that. So it's extremely difficult to actually get the needle to go into the canal. All
What if
right?
you did?
What's that?
What happened if you did?
You could damage the nerve.
Okay.
All right, are you guys all logged in? Okay, how do you wanna do this? Because I've got 2 lectures, but I think the homework is together. Do you want me to skip this part, do the second lecture, and then come back and then we go through the whole thing while you guys are on? Let's do that. Because I'm afraid that if I do this and then you get out, then you're not gonna be able to answer the rest of the questions and then you'll
It does
feel.
say unlimited time.
But if you get out of it, I don't know that you'll get back in. Yes, I gave you plenty of time to do it, but let's just hold off on that until, I'll tell you what, let me just pull this up. I saw someone had this anesthesia diagram. This thing is really nice because this shows you, if you're giving a specific injection, this is the area that will be anesthetized. So if we give the PSA, we know that we're gonna get all the maxillary molars except for the mesiobuccal root of the maxillary first molar. For the MSA, we're gonna get the premolars and the mesiobuccal root of the first molar. And what's the special thing that I talked about back in head and neck about the MSA?
Some people don't have one.
Some people don't have it. A lot of people do not have the MSA. Does that matter? Does that change the way we're gonna give injections? No. Because if they don't have the MSA, the PSA's coming up a little bit, the ASA's coming back a little bit. If you inject where you would inject for the MSA, you're gonna get those branches.
I
Okay?
got a question.
Yeah.
If you're doing something on the maxillary first molar, would you use like 2 separate carves for the PSA and MSA, or just like
No.
3/4 and then like 1/4? Okay.
Yeah, typically if I'm gonna be working in, the textbook way to give an injection, if you were just giving a PSA infiltration, you would use 1 cartridge.
Okay.
If you're gonna be working kind of side by side, you don't necessarily have to give a whole cartridge for the PSA and a whole cartridge for the MSA. You can kind of spread it out. So like when I would anesthetize, I had a hygienist who did not have her local, and when I had to anesthetize, if she was doing a half mouth, I would use 2 cartridges on the top and 1 on the bottom. And we had plenty anesthesia, okay?
That was it?
That was it, half mouth. Yep. But I'm good. All right, ASA, gonna get the maxillary anteriors as well as the soft tissue. Greater palatine is going to get the palatal, or the hard palate, up to, but not including the canine. Nasopalatine is going to get canine to canine on the palate. The IA, this always confuses people because when we talk about the IA, what you have in your mind is the IA block, okay? When we give an inferior alveolar block, what happens is you're gonna get the IA and everything that branches off of the IA, okay? But when we're talking technically, the IA only gives you sensory innervation of the mandibular molars and the second premolar, okay? The incisive branches off of the IA at the mental foramen. So it's gonna get the first premolar and the anteriors. So if I ask you what injection you would need to give in order to anesthetize that mandibular canine, it would be perfectly acceptable to say the IA, or it would be perfectly acceptable to say the incisive. I would rather you tell me the IA because you can't give an incisive injection. Okay, does that make sense? But if you give me either, I would accept either because both are true. Okay? All right, so the mental is going to give you the soft tissue of the first premolar and the anteriors on the buccal side or facial side. The lingual is going to give you half of the tongue, as well as the lingual tissues of all of the teeth on one side. So if we give an IA block and we get the lingual as well, then you're going to get all the anesthesia of all of the mandibular teeth on the one side, the lingual tissues of all of the teeth on one side, half of the tongue on the same side, and the facial tissues from the first premolar to the central incisor. So we would only have to give one other injection to get this tissue here in order to get it all. And that one is the long buccal. So when you guys are in clinic and you give your IA injection, the expectation is as soon as you come out from doing the IA, give the long buccal. So that way you'll have anesthesia of one side of the mandible. It's a pain if you're only going to work on tooth number 26. You have to give an IA block. So they're going to have the whole half of their mandible is going to be anesthetized in order to work on that one tooth. Unless you're lucky enough that you can infiltrate that one. But you can't always get adequate anesthesia by infiltrating. All right, so that's those. So you guys have access to that. I would suggest that you do print that off and bring it with you when you come into the clinic when we're practicing the injection so that you can see exactly where you're going to be anesthetizing when you give each injection. Okay, so now we're going to talk about what equipment you use, and we're going to talk about some technical things, okay? So first of all, there are different types of local anesthetic syringes. We have different types in the clinic. The most common type, and all of the ones that we have, are what we call breech loading. What that means is that when you put the anesthetic cartridge into the syringe, you're putting it in from the side. So breech loading just means that you're putting it in from the side. And there's going to be an aspirating syringe, which allows us to be able to determine if we are in a vessel when we insert that needle. There are regular and petite syringes. We will measure you guys so that you can get the best fit. We will find that some people will measure you and say, oh, you probably could get by with the petite, and then you find that you're better off with a regular. There'll be some the opposite. You say, oh, you're a regular, but you get the petite. Just realize that when you get into your offices, they may not have petites. Most offices have regular syringes, okay? So make sure that you have at least tried using a regular syringe, unless you work for somebody who's really nice and will go out and buy you something just for you. There also are winged and wingless. So where you hold this syringe with your fingers, your thumb's going to go in the thumb ring. Where you use your fingers to hold this, some syringes have these wings that come off the sides of them, and some just have like a little lip there. Okay, so there's winged and wingless. Again, I believe we have both of those here in the clinic. So when we look at the parts of an aspirating syringe, we first have the thumb ring. This is a regular, this is a petite. Okay? There's the finger grip. So this particular one is a winged syringe. There's a wing on the finger grip. The barrel, this is where the anesthetic syringe is going to be put in. This is breech loading because it's going to be put in from the side. On the inside of this barrel is this piston with a harpoon. Okay, so it's got this little harpoon, looks like a harpoon you would shoot at a whale. Okay? That harpoon is gonna engage into the rubber stopper in the back of the syringe. The harpoon is what determines that this is an aspirating syringe. Because if you did not have that harpoon, when you would pull back to aspirate, it wouldn't pull back anything. By having the harpoon, it engages in that stopper, so when we pull back, it pulls that stopper back a little bit, and that's how we aspirate. Okay? That might be a question from Howard. All right, there's a spring in there, because these are spring-loaded syringes. And then there's a needle adapter. So this is where the needle is screwed onto the syringe. You want to pay careful attention to this needle adapter, because the needle adapter has a screw end that screws into the syringe. If you go to take your needle off and you unscrew the needle adapter instead of unscrewing the needle, and then you throw that needle into the sharps container, this syringe can no longer be used. We have to throw it out because we cannot get into the sharps container in order to pull something out, okay? So make sure when you remove the needle that you're not removing the needle adapter. If you see that it's starting to unscrew, get one of your faculty members and we'll get it apart for you, okay? All right, when we look at the needle, obviously the needle is going to take the solution from the cartridge and put it in the patient when we push down on that thumb ring, okay? So the needle is designed to deliver the anesthetic solution to whatever tissue you're placing that injection. Sharpness and angulation are going to be extremely important. If you have a dull needle and you try to put it through the tissue, it's going to be extremely uncomfortable for the patient. If you go to do an injection and you accidentally hit the bone, what's going to happen is you're going to bend the little barb, or you're going to create a little barb at the end of the needle that is going to have to pop through the tissue when you give the injection. So if that happens, you want to get a new needle. If you have to give multiple injections, you may want to get a new needle at some point because the needle will get dull, a little bit more dull every time you use it, okay? With angulation, you just want to be careful that you're not placing the needle in the wrong angulation because you might hit something that you don't want to be hitting, okay? So you might be hitting bone if you don't have the needle angulated correctly. There are different sizes of needles. There are different lengths, and there's different sizes as far as the opening of the lumen of the needle. The sizes are called the gauge of the needle. When we're looking at the size of the lumen, that is the gauge of the needle. The determination of what gauge you're going to use is going to be determined by, first of all, how deep do you need to go to give that injection? The deeper you go, the more the needle can deflect, and so you want a little bit thicker needle so that it doesn't deflect as much. If you need to aspirate, you need a bigger lumen than if you don't need to aspirate as much. Never bend a needle. I see that a lot. A lot of our dental residents would bend the needle because then you can get a little bit better angulation. The minute you bend a needle, you would weaken the needle in that spot. I have seen needles break. We've had to remove broken needles out of patients. Luckily, we had one that broke, that part of the needle was still sticking out of the tissue. We were able to grab it with some hemostats. We had another one, luckily it happened to be on an oral surgery day where we had an oral surgeon. The oral surgeon had to cut that patient open to get the needle, okay? So never bend the needle. When you go to discard the needle, don't bend it dead either. A lot of offices will take it and bend the needle, and that's so that they won't use it again, by accident. The problem is that when you try to put the cap back on, it doesn't go on very well. So never bend a needle. And if you meet resistance, don't try to force it. If you don't have the proper angulation, you may be hitting a tendon when you're going in, or you may be hitting the bone. If you get that resistance and you try to force it in, it's gonna bend the needle. Or it's gonna deflect the needle, or it's gonna cause it to scrape the periosteum, okay? So don't force it if you need resistance. And then you never, ever, ever insert a needle all the way to the hub. The hub is gonna be the weakest part of the needle. So if you insert it all the way to the hub, and for some reason patient jumps and that needle breaks, it's not common, okay? It's not easy for that needle to break, but it can happen. And if it breaks at that hub, then I guarantee you, you're not gonna be able to retrieve that needle, okay? Oral surgeon will have to do it.
So if you feel like a lot of resistance, should you just remove it? and
You don't
reinsert it?
necessarily have to remove it all the way, but you need to pull back and reposition it.
Okay.
Yes. All right, so when we look at the tip of the needle, so this is the part that goes into the patient. There's a little bevel on it, okay? You want to have the bevel facing the bone, okay? If you look at your syringe, the syringe usually has a little marking that tells you which way is the back of the bevel. So if you have the marking facing you, then you've got the bevel towards the bone. Okay? The reason is number one, it gets the solution going in the right direction. The other thing is there's less chance of catching the periosteum with the needle. Now, sometimes when you screw a needle in, because of the way it screws into the syringe, you know, there's a window on the syringe that you have to be able to see if you're aspirating. And so if the needle doesn't screw in right, sometimes you have to make a choice. Do I want the bevel towards the bone, or do I want to be able to see the cartridge through that window? The cartridge through the window is your number one priority. So if you have to put the bevel away from the bone in order to be able to see through that window, then that's what you do. Okay? So in the textbook perfect world, the bevel will be facing the bone, so it'll be in this direction like this, and you'll be able to see in that window. All right, does that make sense? Yep, okay.
What's the top part of that picture indicating?
That's showing how it got stuck into the periosteum. So here's the bone, that's the periosteum. So the needle went into the periosteum.
Oh, okay.
This is the area where I said if you hit the bone, sometimes you get a little barb. So the end of this bevel may bend back, and now you've got this little barb on it. Okay? All right, so let's look at specific needles. There are different lengths of needles. There are long needles, short needles, ultra short. This gives you the length. I'm never going to ask you the length. Okay? You're not going to have to memorize the lengths. Just realize that the long needle is longer than the short, and the short needle is longer than the ultra short. Okay? When you look in the clinic, you'll be able to see which one is a long needle, which one is a short needle, and which one is the ultra short. The ultra short is really tiny. You may never, those of you who work in dental offices may never have seen an ultra short. Okay? Typically, the ultra short is used when you're giving a PEL injection. Okay? All right, the gauges. We know that the gauge is the size of the lumen, or the opening within the barrel of the needle. The lower the gauge number, the larger the lumen. So a 25 gauge needle has a larger lumen than a 27 gauge needle. A 27 gauge needle has a larger lumen than a 30 gauge needle. Typically, the gauges are going to be color coded. So if you have a 25 gauge needle, that cap on that needle is going to be red, or it's going to have red markings on it. If it's a 27 gauge, it's going to be a yellow cap. Sometimes it's an orange cap, or it's going to have yellow markings on it. And if it's a 30 gauge, it's going to have blue or light blue. Some manufacturers will have a violet or a clear, so that you can actually see in it. Because the ones that we have, the 30 gauge short needles and the 30 gauge ultra shorts look exactly the same with a cap on. You have to really peer through it to see which one's the ultra short, okay? So some manufacturers will put a clear or a light violet color so that you can see the difference. The 25 gauges will come in a long and a short. The 27s will come in a long and a short. The 30s will come in a long, a short, or an ultra short. So if you had to penetrate fairly deep to give your injection, a 30 gauge long would not be the best needle of choice because it's going to deflect more. Okay? So if you had to go really deep, you might choose a 25 or a 27. Now, a lot of people think that the size of the needle, the bigger the size, the more pain to the patient. And that's not true. People don't really notice when you're getting the needle, it's not the needle that causes the discomfort, it's the solution being injected that causes the discomfort. Okay? The needles will all come in a metal hub or a plastic hub. The ones that we have right now, the plastic hub, I don't particularly like them because it's very easy to screw them on too much and then they get stripped. I like the metal hubs, and so we're gonna actually switch to the metal hubs. All right, so here's some different needles. So you can see this is a 27 gauge long. It is a yellow cap. 27 gauge short. This one is an orange cap. Sometimes they come in yellow. The ones that we have, both the long and short, are yellow, but you can tell the difference because of the length of the cap. This is a 30 gauge short, and then this is a 30 gauge extra short. So this happens to be the violet. The ones that we have, both of them are blue. Okay. So again, weakest area is at the hub. So we never want to bend it. We never want to insert it all the way to the hub. And we already talked a little bit about deflection. The needle will deflect more the longer you have to go or the farther you have to penetrate the tissue. Also the gauge of the needle, so you have a thinner gauge or smaller gauge, it's going to deflect more in the tissue than what a larger gauge will do. And when I say larger gauge, lower number. Okay. The bevel angle, because of that bevel, it may deflect the needle a little bit. Bevel doesn't really do a whole lot. And the bevel placement, again, if the bevel's going to turn the needle away, if you have the bevel facing away from the bone, it could deflect it away from the bone if you penetrate farther enough. And then ease of aspiration. As the size of the needle or the size of the lumen gets bigger, the easier it is to aspirate. Therefore, the smaller the lumen size, the harder it is to aspirate. So it's much easier to aspirate with a 25 gauge needle than it is to aspirate with a 30 gauge needle. All right, so we already mentioned the gauge is the size of the lumen of the needle. The smaller the gauge number, the larger the size. And then we're going to determine the gauge size based on how far we need to penetrate in the tissue and if there is a risk of intravascular injection. If I'm going to give an IA, I don't want to use a 30 gauge needle because I can't aspirate well with a 30 gauge needle. If I'm going to give an IA, I'm typically going to choose a 27 so I can aspirate well. If I'm just giving an infiltration, maxillary infiltration, there's less blood vessels that I need to worry about because the blood vessels are kind of traveling within the bone, not around it. So I can use a smaller gauge or I can use a 30 gauge because I don't have to aspirate as much with those injections. So the anesthetic cartridges, they are color coded. So you don't have to sit and read the whole cartridge. It doesn't matter what manufacturer. If I'm going to have a 2% lidocaine with 1 to 100,000 epinephrine, which is probably the most common anesthetic out there, they all are going to have a red band on them. The only ones that can kind of trip you up are the 3% mepivacaine, which is a tan color, and the 4% articaine with 1 to 200,000 epinephrine, which is a gold color. Sometimes they look awfully close. So you want to be careful that you're looking at those to make sure that you've got the right one. If we look at the anatomy of a cartridge, this is the part that goes towards the needle. So the needle's going to poke through this diaphragm that is placed within this aluminum cap. The anesthetic is in here. The anesthetic will be listed as to what it is. There'll be an expiration date on it. They also have a barcode now, which is a pain in the butt, because when you put the cartridge in the syringe, you've got to make sure that you've got the cartridge turned so that the barcode is not preventing you from being able to see the contents of the syringe when you aspirate. This is the color code band, and then there's a silicone rubber stopper, or plunger. So this is where the harpoon is going to be engaging within that cartridge. Now, when you read the cartridges, if you really have nothing better to do, and you want to read the cartridges to see how much solution is in each cartridge, they're all a little bit different. Some have 1.8 milliliters of solution, some have 1.7 milliliters of solution. We teach you 1.7 for everything because that's what they use on your boards, okay? When you get into the office, the dentist that you work for may be more particular than that, and they may want you to use the actual amount. So like 2% lidocaine has 1.8 milliliters. But when we're figuring out dosages and stuff, we use 1.7 because that's what your board test will use. Yes?
Have you ever seen the automatic syringes?
Mm-hmm.
Those are really cool. Like
Those are cool,
how
but
does
yeah,
it
that
itself?
takes the fun away from it.
Yeah, yeah.
All right, so when you pull out a cartridge, you want to inspect that cartridge. Make sure there's no cracks in the glass, make sure there's no problems with it. Sometimes you'll see bubbles in the solution. If they're just little bubbles, that's just the nitrogen that was put into the solution, and that's nothing to worry about. If you see a larger bubble, then you want to get rid of that syringe, because most likely it has been frozen and then re-thawed. Okay, so you want to get rid of it if it has this large bubble. Typically when it has the large bubble, this little plunger or stopper will be extruded from the cartridge as well. So when you look at the plunger, if it's even with the glass, the edge of the cartridge, or it's slightly indented, that's okay. That's normal. If it's extruded, like this one, you want to get rid of it, because there's no guarantee that that is sterile. So you could be injecting something that has been contaminated. So when we put the syringe together, you want to put, and for those of you who've worked in dental offices before, you may do it a little differently. We're going to teach you the way that the boards want you to do it. When you go into the office, if your dentist wants you to put the syringe together differently, that's okay, all right? I personally don't do this. I put the needle on first. But I teach you, so it's do what I say, not what I do, okay? Because that's how I was taught. I was taught to put the needle on first, okay? You have to be careful when you put the needle on first because it's very easy to bend the needle when you're putting the cartridge in. But what you're gonna wanna do is take the syringe, pull back on the plunger, and insert the cartridge into the opening on the side of the syringe. Once you have it done, then you want to put enough pressure that you engage that harpoon into the little stopper in the back of the syringe. So as you can see, I don't know if you can see it or not, you can see it here. You see how the aluminum cap is going to go towards where the needle is, and the stopper is going towards the harpoon, okay? So you want to engage that. Don't put too much pressure. Some people really force it, and And what will happen is as soon as you put that needle on, you have put the solution in so much pressure that when you put the needle on, it just starts squirting out the needle into the cap. And by the time you're ready to give the injection, half of the solution is in the cap. Okay, so don't press too hard, just enough to engage that harpoon. And then again, always make sure that the large window is facing you so that you can see the contents of the syringe when you aspirate. All right, so once you have this in place, then you attach the needle. Okay? Once you've done that, you always want to inject, or you want to eject a couple of drops of solution. That's just to make sure that you put the thing together correctly. Sometimes when you're putting this end in, you bend it. It's more common to do that if you put the needle in first and then put the cartridge in. It's very easy to bend it, so you have to be careful with that. But when you're doing this, sometimes you bend it and it's not engaged into the cartridge. So if you try to eject a few drops and nothing comes out, then something's not right, and you're gonna have to check to see what's causing the problem. When we aspirate, we're gonna take the needle and put it into the person and get it to the final resting spot. Once we're in the final resting spot, then we're gonna aspirate. Why do you think we do not need to aspirate as soon as we insert it into the tissue?
That's not where the going.
You're not gonna be injecting there, okay? So as soon as you put it in the tissue, there's no reason to aspirate because you're not gonna be injecting anything there. So you wanna get the syringe into its final position, then aspirate, okay? When you aspirate, you only wanna pull back about 1 to 2 millimeters. Don't go crazy and try to pull, the person's body fluids out with the syringe, okay? You just need to go back 1 to 2 millimeters, and you're gonna watch for blood in the cartridge. If you see blood coming back into the cartridge, you're in a vessel. If that happens, pull back, reposition, aspirate again. Now, if you get into an artery, what'll happen is when you aspirate, blood will flow into the cartridge. Okay? Not a problem, other than the fact that sometimes it fills that cartridge up enough that it's now all red. If that happens, you need to replace the cartridge because you can't see when you actually reposition it and aspirate again, okay? All right, so some safety and sterility, recapping, that's gonna be a biggie, okay? You never want to recap with both hands. They call it a hands-free technique. It's actually a one-handed technique, okay? So when you recap, you never take the syringe in one hand, the cap in another hand, and try to put it together. Okay, you are on the risk of poking yourself with a dirty needle. If you need to change cartridges, then you need to recap. Unfortunately here, what you have to do, if you need to change the cartridge, you have to take the needle off, cartridge out, new cartridge in, needle back on, okay? We will give you extra needles and extra solution when you guys are working on each other. And you want to do the same thing if you're working on a patient. You want to have extras available just in case. But don't put them on the tray table because they're considered disposable items. So if you put it on the tray table, it is now contaminated. Whether you used it or not, it's contaminated. Some offices will wipe it off with an alcohol swab or something like that. I've known offices that have put it in cold sterilization. You can't do that. You have to throw it away. So what you want to do is the extras, have them in like a little cup off to the side or laying off to the side. If you need to get another one, you can just put an overglove on and grab what you need. Or if someone's assisting you, they can grab it for you. Okay? And then once you're done, you want to make sure that you remove the capped needle and the used cartridge and put them both in the sharps container. Okay? All right, so this is the scoop method. So they're using one hand, they're scooping the needle into the cap and pushing the cap on. When you guys first do that, the majority of you will be chasing it around the tray table, okay? Just expect that. We will give you a little hint that you have a mirror. You can use the mirror, or if you have like a cotton tip applicator or something, put it on there, put the cap against that. So as you're scooping, you have something to kind of hold that cap a little bit. Now, sometimes it just pops over it and keeps moving it around. What you don't want to do is if you have a mirror on your tray table and you have the cap on the table and you go to use the scoop method and you take the mirror and push that on, it's now two-handed. Okay, so it doesn't matter if you're using a 6-foot, 2x4 to hold it, it's two-handed, okay? So you cannot do that.
Not touching.
A lot of offices will have these recapping devices, okay? The metal ones, hopefully the office sterilizes them in between. Some offices that just, it's sitting there and they just kind of reuse it, which is kind of nasty. But there are recapping devices where you can use that to put the cap in and then scoot it in. Now you don't want to hold the recapping device to put the needle in, okay? All right, so pull up, if you don't have it up, pull up eLearn. And we are gonna start with question number 1. All right. Is everybody on? Everybody be on, and then you can, once you're on, go ahead and hit start quiz if you haven't. Has everybody started their quiz? Yeah. Anybody who has not? We're good? Okay, so we're gonna do this as a group. The thin epithelium and abundance of loose connective tissue found in the buccal vestibule of the maxillary arch allows for easy penetration of the needle and provides ample space for the deposition of anesthetic fluids.
True.
True, because that tissue can stretch and move, and it's thinner, it's non-keratinized like the palate is, so it's much easier.